Hello everybody, I'm here to go over our Project Fusion What's Changing slides. So what this presentation is a overview of some of the changes that we know that are specific to our behavioral health module that will be going live in our enterprise go live date at the end of July. For those who do not know, we will be going live with a behavioral health module. So what this means is that both for Bellin and Gunderson, we did all need to change how we document and do our work. And we were grounded in the principles of looking at foundation system build first and then aligning wherever possible. Any deviations from alignment were needed to follow an escalation path in order to make any exceptions. And what we do know about this project is for those of you who were here when we went live on Epic about, I don't know, 12, 13 years ago, what we did is we gathered all of the data that we needed to move forward with our electronic medical record. And then we knew that going forward, the next few years, we would spend time trying to perfect that tool until it became what you're used to in Epic today. So I'd like us to just kind of ground ourselves in realizing that this is really Project Fusion phase one. So we have spent the last few months gathering all of the tools that we need to take care of our patients and do it in a safe, effective manner, knowing that it may not be 100% perfect and that we will be spending time over the next few months, years to get the system to perform for us optimally and leading to efficient documentation and sharing of those records. So I am going to be going over, like I said, just some of the changes that we are aware of so far. So for this process, we'll be using what we call as our what's changing slides. So the slides will contain information that pertains to both Gunderson Health System as well as Bellin. And there will also be information about inpatient and outpatient. So I will do my best to highlight the information that pertains to us here in inpatient and all roles. So one of the first areas that we're going to start with is called behavioral health episodes. So what episodes are, it's related to clinical encounters, and it is a way to kind of organize those encounters. So for example, we use episodes for different outpatient services and an inpatient. When someone comes into the hospital, that inpatient stay is going to automatically create its own episode. There are also different triggers that can be associated with that episode for timing of the treatment plan, and that will be one of the activities that will be really important for our outpatient folks. However, for our inpatient care, what will happen is we will automatically create a new episode every time that a patient is admitted into the hospital. The only reason that I'm making you aware of this is because it can have to do with the way that things are organized in the chart. And when we get into the treatment plan activity, you will see this organized in the episodes as well. So again, inpatient episodes will automatically be created upon the patient's admission. Basically, your providers will not interact with these during that admission process at all. And they will automatically be resolved once the patient is discharged from behavioral health. So each inpatient admission will be a separate episode. All right, the next area that we're going to talk about is the behavioral health questionnaires and e-consents. We have a lot of questions that still remain on how the e-consents will work, but I will explain the basic functionality and our plans and intent for this workflow. So with Project Fusion, we are unifying consent documentation where appropriate for behavioral health. So a team met and did go through our current consents for both inpatient and outpatient, and we did align on as many that we could involving legal to address some of the differences in the way that we approached consents in both of our regions, and we feel like we've landed on some good options. So most consents today are on paper. Some are electronic for Gunderson currently, and those will remain electronic. Where needed, we will still have the ability to use paper and obtain a paper signature for electronic forms. So I do want to mention that there are two different terms here. One is e-consent, and what that actually is that the consent that we currently use is available as a digital version inside of Epic. And then there's e-signature, and that is where the patient is electronically signing, either on an iPad, on a phone, or a MyChart, or even on a desktop. You can do it with a mouse. So those are just some differing terms that we'll be utilizing throughout this presentation. From a hardware perspective, we will be using iPads primarily for e-signatures. Our outpatient folks will be using Topaz devices. So if you've ever received any care in any Bellin outpatient clinics, those are those little electronic pens, or basically kind of the way when you sign for a credit card. It looks very, very similar. Like I said, we will be moving towards iPads and potentially Rover devices for e-signatures. So things that were in scope for the e-consents for us in behavioral health, these are all the different documents that we looked at. Some of them pertain to us in inpatient, some of them do not. Treatment plans, those treatment plan staffing forms that we review on Mondays, Wednesdays, and Fridays that require signatures. We will be having those built, admission consents, treatment consents, and video photo and video consent will also be built. One thing that will not be for inpatient is our medication consents will currently remain on paper because we were not able to find a way that would meet the needs of both of our areas at this time. So inpatient e-consent, so we will use MyChart Bedside. This is what I'm referring to when I refer to the iPads. It's the same process by which we currently have providers see patients electronically, where you have to create the QR code, scan, and link the iPad to the patient's account. So here they will be able to be presented with a consent that needs a signature. And as you can see, there's a spot to sign, and then the account needs to be unlinked or removed prior to using the iPad with the next patient. So this is just kind of a brief picture of what that looks like. Where you can view e-consents, if you can see, they're under consents activity and documentation activity once they're completed. So you can kind of see a picture here of what one looks like after someone has completed an e-signature. And then Project Fusion workflows and documentation. So this is a little bit more broad. And what this is the implementation of the Stanley Brown Safety Plan. So for those who work in intake and are aware of our referral form that we currently use for safety planning in intake, that will be changing to the Stanley Brown Safety Plan that is currently built in Epic. The nice thing about the Stanley Brown Safety Plan is that it can stay with the patient's chart and follow them in outpatient and is viewable anywhere. And it can be sent directly to the patient's MyChart so they can access it at any time, and it can still be printed out as well. So in all settings of care, the clinical documentation, flow sheets, navigations, and required documentation, etc., may have minor changes as part of Project Fusion as well. And that is one other thing that we did want to note. There will be some minor changes in inpatient flow sheets for us here at Bellin. So what is changing? So we are going to start completing clinical documentation in the new and updated flow sheets and navigators. And we are going to have some simplified versions of note types. We're not going to have quite as many options for note types as we've had historically. And you will see a little bit more information when you go to training. Again, I do want to point out we're not trying to show you every single option and every single way that you will complete this documentation. What we really want to do is communicate to you what the changes are so that you're seeing and hearing about them for the first time here as opposed to when it's time for training. So at the time that you arrive for training, you should be there and kind of have a basic understanding of what things are changing, but you may actually see for the first time what it will look like when you present for training. All right, so in the Bellin region, things that we are going to stop doing, protecting therapy encounters behind break the glass and sensitive note types, which we'll talk more about in the HIPAA harmonization section. And then we will stop protecting psychiatry encounters behind break the glass. Things that we will do is obviously trying to continue to document in appropriate areas and continue using department and individual smart phrases to document. We are going to be importing as many smart phrases as possible. However, exactly how many that is has still not been determined. So next area that I alluded to is going to be HIPAA harmonization and information blocking. This is also specific for outpatient with relationship to and inpatient for the substance use note sensitivity. So today, the entire Bellin Psychiatric Center is behind break the glass, regardless of a patient diagnosis. However, at Gunderson, today all inpatient encounters are open to all staff and providers within the organization. And the decision has been made by the legal team that patients at BPC, regardless of diagnosis, other than those related to substance use, um, will not be behind Break the Glass, but substance use records, according to the law, will remain behind Break the Glass. Now, what does that actually mean? So, BBC Break the Glass workflow, the way that we will do this is we will default to having our inpatient records for behavioral health open. What that means is that providers within the Bellin system will no longer have to break the glass. However, they will still need to have a reason to view the record um, in order for it to be seen. What that also means is that patients will be able to view their records, including both in and outpatient visits at BPC via MyChart. However, according to the law, HIPAA harmonization, we are still required to provide some sort of substance use information blocking, and how we will do this is through an encounter FYI flag. So this flag will be applied once the clinical determination is made for the patient's encounter to be hidden related to treatment for substance use. So this determination can be made by either registration staff or the clinician. So essentially, if we are aware that an individual is coming in seeking detox treatment with us, we will automatically at time of registration implement the FYI flag. When I say automatically, I don't mean that it will just happen. We will have to enter that flag. And what that will do is it will put the entire encounter behind break the glass, meaning that it will not be able to be viewed by anyone outside of Bellin Psychiatric Center. The episode and the inpatient encounter will automatically be placed behind the break the glass once that encounter level FYI flag is created. And then BPC leadership and the legal team will communicate expectations around exactly what will constitute when that should be implemented. So, things that we need to start doing. So, for inpatient substance use patients, we're going to be using that encounter level flag at BPC to hide patients behind break the glass if they are here for substance use treatment. If patients request to have an encounter behind break the glass, and providers will have to reach out to the privacy officer in order to get that put in place. So the thing we'll stop doing is stop placing all encounters behind break the glass for BPC, and sensitive notes will no longer be utilized in the Amplify system either. Gunderson will essentially continue to use the same workflows for both outpatient and inpatient that they're using now, except for the addition of the BHS episodes in the outpatient setting. What Gunderson does is they use a BHS, which means Behavioral Health Specialty, and they use that qualifier to designate their substance use records. So they have separate visit types and encounter types, as well as episode types that have that BHS designation, and that is what places those documents behind break the glass. So workflow expectations. So if a patient is determined to be a substance use patient during their registration, BPC registration staff will create an encounter level FYI flag to ensure that the patient encounter remains behind break the glass. And if a patient is determined to be a substance use patient during their admission at any point, then the clinician will be responsible for creating the encounter level FYI flag to put the patient behind break the glass, and information and instructions on how to do that will be provided. Inpatient treatment plans and care plans. So the care plan tool will be used in the inpatient setting of all care to document problems, goals, and interventions on a patient's chart. We currently use the care plan activity. However, the treatment plan tool and activity is new for us. And what that is it will be used in Epic to create the patient's treatment plan and to update it during their admission. It will automatically pull in documentation from the care plan, and it will include a section for a treatment plan assessment note as well. And so that treatment plan assessment note will be taking the place of our current staffing documents. And as I stated, it will pull in documentation already from the care plans, and the patient will have the opportunity to sign them electronically. Um, so we will be working, it says, with Michael and Noel. Those are our analysts who specifically design that content, and have separate treatment plan content for us that is different than the inpatient behavioral health unit for Gundersen. All right, so high level, the workflow basically will be that we will create the patient's care plan following their admission to BPC. This will include adding and customizing the problems, goals, and interventions for the patient's admission. We have simplified the different types of care plans that we will have available, and they have been scaled back quite a bit, but we have found that the interventions that were available in the foundation system were actually far superior to what we currently had built in our system. We will be bringing over a handful of care plans from our current system, but we ultimately determined that we liked the foundation system build much better. So we'll continue to document progress on the patient's care plan during their admission, and this will be done each shift, generally by the nurses or behavioral health specialists or therapists. We'll then create a treatment plan for the patient in Epic using the new treatment plan activity. So we'll create and contribute to the treatment plan assessment note, update the effective from date. We removed the effective to, so it will basically just have the date that we are completing the staffing. And we'll add appropriate contributors before we finalize the plan. So individuals that are listed as contributors or needing to sign, those individuals will be identified through the staffing process based on who is present, and we will add their names, and there's a couple different ways that we can get that signed. It can drop to in baskets, so we can participate in staffing, and then you'll be marked as a contributor, and if you're needed to sign, what will happen is you'll get a little message in Epic that you can just electronically sign the document by adding your password, and that will prevent us from having to shuffle around all those folders 3 days a week. So we're hoping that that will be a bit more efficient. We're currently determining who should be marked as a contributor and who should be marked as must sign. So we have not yet determined that at this point. We'll then, like I said, use the MyChart bedside to review that treatment plan document with the patient and ultimately have them sign. So we do have the ability to collect signatures if needed. If you can see here, the picture that you see on the left here is what the treatment plan note will look like. We have some predetermined content that is fairly identical to our current treatment plan. Our treatment plan review sheet, and then it automatically pulls in current progress on care plans. And then on the bottom there, you see that you have the place for signatures for the patient. Collecting signatures on paper, we would do that by printing it out, and then once it's signed, we would mark that the patient signed in the treatment plan, and then the signature would get scanned into the rest of the chart. Safety checks and precautions. So we will be going live with safety checks on rovers and mobile devices. So the decision was to implement safety checks that will be documented every 15 minutes for all patients. And we will also utilize this for documenting our one-to-one and line of sight patients. So essentially all that means is the determination was made from both us and Gundersen that even if someone's on a one-to-one or a line of sight, we will still document checks every 15 minutes. They will be scheduled in 15-minute intervals based on the time that the safety check was ordered. So essentially on a mission, there will now be an order for 15-minute checks, and the next safety check will be determined based on the time that that order was put in, and then it will flag for a recheck every 15 minutes. All roles will have access to complete safety checks, but the most common users will be the CNAs, BHS, for completion of these safety checks, but like I stated, all roles will have access. We do know for a fact that this can be completed on Rover. However, that device is rather small, so we are also pursuing having this implemented on iPads, and are in the process of identifying how that workflow would look moving forward. So again, so the provider places an order for safety checks, and this will be included in the admission order sets. Then the end user will navigate to the safety checks list on the Rover device and complete safety checks every 15 minutes for the patients along with other patients on the unit. The one nice thing is that if you have several patients in the same area, you can do a multi-select, meaning that you can document the activity of all 5 patients sitting in the same spot all at once by selecting all 5 patients. So looking at that workflow will be great to see during training. And then our unit managers, we will have the ability to review safety check compliance and help to identify any potential concerns if we're missing checks and see if there's anything that we can do to help assist. You will be able to backdate one safety check, meaning if you are with patients and you're bringing them all down to the cafeteria and you miss one of the safety checks, you will be able to use the Rover device or iPad to go backwards to document at least the one safety check that was missed. However, if there are more than one that are missed, you will have to log into Hyperspace on the desktop in order to do the rest of the back documentation. It is possible, but you will have to change how it is done. All right, so things that we'll start doing is completing safety checks in real time using Rover devices or iPads. We will utilize reports and epics to view the safety check documentation over time and to review any missed or late documentation. We'll be using Hyperspace to back document safety checks with more than one missed check. What we'll stop doing is completing them on paper and then continue completing safety checks every 15 minutes for each patient on a randomized schedule. Suicide screening. There's not a lot in suicide screening for us. This pertains primarily to intake. We currently complete the Columbia suicide risk screening with asking questions 1, 2, and 6 from the screener initially that cascades into the full assessment based on the patient's responses. So we will continue to do this on admission. The thing that will change for unit staff, however, is that currently we ask patients if they are suicidal and if they can contract for safety inside and outside of the hospital during one-to-ones, and we will document it in that format in flow sheets. But after go live, we will be utilizing the CSSRS or Columbia Suicide Risk Scale since you were last asked tool. And what that does is it allows us to document our assessment of suicidal ideation each shift utilizing a validated tool. This is more consistent with the recommendations and regulations for DMV and CMS. So this will help us also align with Gunderson. So what we're really asking the patient isn't going to change too much. It's just a matter of how we document it. And that will be updated in our flow sheets. Violence assessment and communication. So this is just kind of a brief overview. So many of you are probably aware that the Maya TAPS has been live at the rest of the system for quite some time. With this project, Gunderson has determined that they would like to go live with this tool, and we will start to use it more consistently. We have made some changes to the tool as a task force to make it more effective and to utilize it as a violence communication tool more so than a predictor tool. So how frequently we will do this is we will complete the Maya TAPS on admission and then with any change in condition. What we want to do is make sure that we are identifying patients using the Maya TAPS that are appropriate and making sure that we are utilizing the tool to communicate any past violence so that we can communicate with the rest of the system should this individual arrive, say, in the emergency room or at a clinic. So all individuals that have a score of 5 or greater, or if there is a history of violence, they will have a security alert flag, which is the blue alert. And there is also a section that was added regarding sexually inappropriate behaviors. So if a patient has any sexually inappropriate behaviors, those can be noted there as well. And the goal here is to not only just identify the inappropriate behaviors, but to make recommendations for how to manage that. For example, if we have someone who is sexually inappropriate with female staff members. The recommendation for the presence of a male staff member or for staff to go into a room, not alone, but with a second individual, should be added to this area as well. The same thing for the MyTaps. It's not purely to document that a patient yelled at us, but rather if a patient made threatening statements in a verbally aggressive manner through anything at a staff member or approach a staff member in a violent way in any way, that is what we want to be communicating in through the use of this tool. We also have added the family and visitor violence or family and visitor FYI. So what this flag is for, it is an FYI flag that will allow us to identify any patient visitors that have been disruptive. For those working with children and adolescents, we have had parents or visitors that have been disruptive in the past. There is a way to flag the chart. So you will see a blue alert, but when you hover over the alert, it will state that it's a family or visitor, and you're able to put in the documentation about what individual that might be or what the concern is. So to assure that these different flags are being utilized appropriately, the nurse practice specialists or clinical nurse leaders in the Gunderson area will all be receiving in-basket messages when anyone is made a security alert for any reason, and they will all be reviewed for appropriateness and for addition of any different interventions that should be added for the patient's care in future settings. So here is an example. This is the MyTaps, as you've probably seen. And then you can also see this section below about sexually inappropriate behavior, and then if there's any sort of weapons present. MyTaps will be located in the following places for us. It will be present in the intake navigator, and then it will also be present in the flow sheets. So you will need to look for the MyTaps specifically in the flow sheets if there's a change in condition. Otherwise, we will do it on admission. Another change is that we will be able to remove the MyTaps too. So if someone comes in and is very agitated and they receive medications or stabilize over the course of their treatment, we will be able to rescore them. And as long as they have not been physically violent with anyone, the score will reduce and the blue flag will be removed so that they don't remain a security alert throughout the system if it was able to be remedied with the use of medications or the patient stabilizes. Here again is the sexually inappropriate section and the different items that you can identify as interventions that are selected, and then you also can hit the other and add a comment. And then again, the family visitor alert flag, when you go and put in the FYI, this documentation with the pick boxes will automatically appear for you to fill out appropriately. And this also will trigger a blue alert banner. So it'll be really important that we hover over that blue alert and so that we can see the documentation that is in there. However, we should not be utilizing this information alone to determine whether or not that patient is appropriate for our facility. It really is more of a way to communicate with our peers throughout the system and caring for patients, just to be aware of any potential for violence when working with a patient. There's also an enhanced awareness FYI that was created. What this is basically to identify things that don't fall into the categories of the MyTaps, sexually inappropriate behavior, or a visitor. For example, if the patient has a history of bringing in any sort of contraband, or if they've eloped from the facility before, or if they've self-harmed with certain items, you can communicate that discreetly in this area, and this also will flag. So this can be really helpful for us in being able to communicate different things for patients when caring for them if we need to know about something that was historical. So again, here's some pictures of that blue banner, and if you hover, you'll be able to see more specifics. And then there is also a patient list row that will turn the individual blue that will be built in the new system as well. And again, we will be getting in-basket notifications to review all of these, and then if there is anything from there that we need to put in any further mitigation strategies or work with workplace violence, we will do so. Group documentation. So this is one of the last areas that we'll talk about. So group documentation, it will be done by a variety of different behavioral health users, both in inpatient and the outpatient setting. And we have a list of available group topics that will be different for both inpatient versus outpatient, and then also for Gundersen versus Bellin. So what we will start doing is we will be using the smart text to effectively document group notes for both inpatient and outpatient groups. And we'll complete group level notes and then personalize those notes for each individual patient. How this will work is you will be able to select the number of participants in each group, and there is some predetermined documentation that will automatically flow in, and that area will be the same in each patient's note, the top portion that talks more specifically about what the group is actually about, how many participants they were, how long it was, and the specific things that were covered in the group. And then you are also able to add on the bottom half of the note information that's specific to that patient and either the way that they processed that information or participated in your particular group. Another change will be is we will be using group documentation now as the mode for documenting learning labs by our behavioral health specialists. There is a specific group type titled learning lab, so you will start documenting them in the group documentation as opposed to documenting them in the education section of the patient's chart. The things that we'll stop doing is stop writing individual notes for each patient who attends a group session. So each patient will end up with their own note. It's just we will be using the group documentation function in order to file this. And you will learn more about that for our therapists and our behavioral health specialists in your individual training. We will stop manually writing out group level information in each note. And you will not have to add yourself as the facilitator. If you're starting the group, you will automatically be considered the facilitator, but you can also add additional individuals. And things that we will continue doing, I apologize, I just went past it. You'll continue to document groups in the chart. So here is some available group topics, and this has since been scaled back quite a bit. And when you go to search the group topics, you'll be able to type BPC as a synonym in all of the different group documentation types that are available for BPC providers and or those facilitating group will show up for you to pick from. So workflow expectations. So what we want to make sure is that we understand how to complete group documentation and ensure that accurate documentation for the correct group and correct patients is in each chart. We want to document in a timely manner per the agency policy. We don't want to leave any unfinished group documentation. It can create some issues with the ability to close and manage those group notes if they're not completed during the date of their occurrence. So we want to have a basic understanding and general workflow and or where to direct group facilitators if we have questions, and we will follow up on anything as needed related to insufficient, inaccurate, or untimely documentation. So there are going to be reports that we are going to be using for each of these changes to monitor their success and look for gaps in areas that we can improve. As I stated earlier, none of this is going to be perfect on day one. So we are all just going to go through our training and do and work through it the best that we can. We will have super users available on all shifts to assist with for answering questions, additional training, and different setups for your individual logins. And you will have at the elbow support for a period of time. And we will also continue to gather feedback and use that in the continued improvement process. Now, if you have any questions specific to anything that was seen here today, you can feel free to shoot me an email or Pam an email or just let me know when you see me in the hall. I'd be happy to answer any questions. So we still have about a good 4 months or so left before we are ready for go live. So we are kind of in the on the phase now where we're making some of our final decisions, and we'll start heading through training. But we look forward to hearing any feedback and any thoughts. And if you have any questions, like I said, you can email me at any time. Thank you.